Hello, my name's Jerry Nolan. I'm a consultant in intensive care in Bath, the United Kingdom, and it's a pleasure to talk to you about CPR in the context of COVID-19, certainly a challenging topic for many of us. These are my potential conflicts of interest. I don't think there are any particularly relevant to this topic, other than perhaps my role in the European Resuscitation Council that has produced guidelines for CPR and COVID-19. So we've got 12 minutes to cover quite a broad topic, but I'm going to talk very briefly about the epidemiology of cardiac arrest. And I think this may be covered by one of the other speakers in the conference. We'll talk a little bit about risk of virus transmission during CPR, and then PPE and modifications to resuscitation algorithms. So what data we got out there? Well, certainly for in-hospital cardiac arrest, to my knowledge, this is still probably the most prominent study, an observational study from Wuhan in China, of course, where whole COVID-19 all started. These are patients who are more than 14 years of age with known COVID-19 pneumonia. So it's an unusual study that it's collected a lot of these cases, 151 cases with confirmed cardiac arrest, as you can see there, split largely those on the general ward, there's far more of them as you can see, and those on ICU. I'll come back to the survival data in a second in the next slide. But you can see the majority, vast majority of them, almost 90%, are from arrest from respiratory cause, not surprisingly in the context of the severe COVID-19 pneumonias. So here we can see here the 30-day survival based on various subgroups. Location here, cardiac arrest on the ward, perhaps not surprisingly, appallingly low survival rates. And then if we look down at initial rhythm, very few of these patients are in a shockable rhythm as the initial rhythm. And then in terms of overall survival, well, very sadly, as you can see from the slide, really a poor survival overall, just 3%. But if you look at those with a favorable neurological outcome, only one patient, less than 1%, achieved that outcome. For out-of-hospital cardiac arrest, there are lots of observational studies out there. I think this is probably one of the best ones to just show the impact of COVID-19 on out-of-hospital cardiac arrest. These are data from France from 2012 through to 2020. And you can pretty obviously see the 2020 year in red with those weeks from 12 to 17 during that first wave of COVID-19, and a huge increase in the number, the incidence per million of cardiac arrest, as you can see. And I haven't got time to go into the data. I obviously would encourage you to look at this paper. But if you look down, right down at the bottom of the slide, highlighted in red, the survival rates, this is during the pandemic period here, just 13% survival to hospital admission, compared with 23%, both during the non-pandemic period 1, which is weeks 12 to 17 of those years that I've shown you, and then pandemic period or non-pandemic period 2 are all the other weeks, almost identical survival rates. Survival to hospital discharge, just 3% during that COVID-19 period, almost a half of what it was in the other period. So a massive impact in terms of incidence and survival. So what about risk of disease transmission? This is a really complex subject. There's a huge number of studies looking at how COVID-19 is transmitted. It's thought, as many of you will know, of course, to be largely droplet spread, but there is probably an aerosol component as well. Aerosols being these fine particles less than between 5 to 10 microns each. The larger droplet transmission is thought to occur mainly within 1.5 to 2 meters, but after coughs or certainly sneezes, that distance may extend right out. As you can see, there has been a study on mannequins and in a cadaver published in Resuscitation recently that merely shows if you put an aerosol in a mannequin and then do chest compressions, you can see the aerosol clearly coming out from this mannequin's mouth and from the cadaver's mouth over here. And that is reduced by placing a viral filter or HEPA filter on the airway, as you can see there. I think key here is whether chest compressions per se really generate aerosol or not. This is a very artificial model because it inserts an aerosol in the mannequin first, and then we just see it being pressed out. It doesn't necessarily tell us whether an aerosol is being generated or not. And there is a huge conflict in terms of opinion on this. Most organizations around the world believe that chest compressions are potentially aerosol generating, and that includes the World Health Organization. Others, such as Public Health England in the UK, are less convinced and they clearly state on their website that they're not considered to be aerosol generating procedures. Although they do add in the most recent recommendations that healthcare organisations can choose to advise their staff to wear airborne protection PPE as required. So the ILCOR has undertaken a systematic review on this. I won't go into huge detail about the questions other than they've been asking whether these interventions, chest compressions, defibrillation or CPR, is associated with aerosol generation, and whether there is a risk of transmission of infection, and whether those individuals wearing PPE are likely or not to get infection, or whether they impair the quality of CPR. So it's a very broad range of questions. There's very little high quality or high reliable data out there. There's two cohort studies, one case control study, and then a lot of case reports. The bottom line here is that there's no evidence that the delivery of chest compressions or defibrillation generates aerosols or is associated with transmission of infection. Mannequin studies indicate that donning of PPE can delay treatment delivery, which is perhaps not surprising. And the evidence certainty was very low, low or very low for all of those outcomes. So we actually really don't know whether chest compressions alone do or do not generate aerosol, and that work still needs to be really done. This is just to summarize the cohort trials and the case control study. Again, there isn't time to go into huge detail about this. I just would recommend you read that systematic review if you want to know more. Safe to say this is all based on observational data from the SARS crisis from a few years ago, and there's no conclusive evidence that individuals exposed to SARS, either doing chest compression or defibrillation, actually were at risk of developing that subsequently. So we simply don't know. Based on that very low certainty data, these are the ILCOR treatment recommendations that have been published on the ILCOR website. So you can go and see those, it's in the public domain. So we suggest that chest compressionals and CPR have the potential to generate aerosols. And you can see immediately from what I've just told you, we've got no data really one way or the other. So it's a weak recommendation with very low certainty evidence. We suggest that in the current COVID pandemic, lay rescuers considered compression-only CPR and public access defibrillation. And then we suggest that in the pandemic, lay rescuers who are willing and trained and able may wish to deliver rescue breaths to children, because of course there's a huge concern that children are going to miss out on the basis of concerns about risk from COVID-19. And then the final two recommendations here are that we suggest that during the pandemic, healthcare professionals should use PPE for aerosol generating procedures. And then we suggest it's reasonable for healthcare providers to consider defibrillation before donning aerosol generating PPE. I think that's important, and I'll come back to that in a second as we go through the next few slides. The ERC have produced guidance on COVID-19. They're available on the ERC website, and they've been published in Resuscitation, as you can see here. The key difference for airborne precaution PPE, which we would use for potentially aerosol generating procedures, is that we need to be using either FFP3 or FFP2 masks, and also long-sleeved gowns rather than just the shorter sleeve versions. So for lay rescuers, as you can see here, the key intervention here is assessing breathing visually and not actually going in, approaching the victim's nose and mouth, not manipulating the airway, calling the EMS, but mentioning the COVID status of the patient, and then potentially covering the victim's nose and mouth. Now, this is the controversial one, and this is just a picture taken from the RCUK website, showing that the idea of placing this veil or cloth over the victim's mouth before doing chest compressions, trying to minimize the risk from COVID-19. And then obviously following advice from the AED when it arrives. This is the version for healthcare trained professionals. And just a few added comments here. Bag mask ventilation, if it's going to be done, it needs to be done very cautiously, because that is an aerosol generating procedure. Ideally put a viral filter between the bag and the mask, and use two persons to minimize the risk of gas leak. It may be that if BLS teams are not skilled or they're uncomfortable in using bag mask ventilation, they should simply put an oxygen mask on the patient's face and allow passive oxygenation during chest compressions. Really importantly, I haven't mentioned this yet, but clearly during the COVID-19 crisis, it's really important to have conversations with patients about their views on attempted CPR or not, and putting in place do not attempt resuscitation decisions where appropriate. As far as advanced life support is concerned, there are some changes here. Again, there's this one in relation to not approaching the airway, but just merely assessing breathing visually until PPE is applied. There's the importance of being able to deliver shocks if required using standard PPE, so before putting on airborne precaution PPE, if the person is in a shockable rhythm, and up to 3 shocks can be delivered while others are donning their full PPE. And then for advanced airway management, where the skills are present, it makes sense to actually go in and perform intubation fairly early on, using a viral filter, of course, and only performing continuous chest compressions without pausing when the patient is intubated. The American Heart Association have come up with similar guidance for them, and I haven't gone into huge detail here about those, but they're just the added points that they've made, limiting the personnel in the room, which makes a lot of sense if there's a risk of COVID-19, possibly considering the use of mechanical CPR if there is experience in using that device. They also emphasize the importance of early intubation, possibly where it's available and where the skills are present. The use of video laryngoscopy may enable that person to just be a little bit further away from the person's mouth and airway. So to summarize, I've covered quite a lot of ground there, and all I can do is highlight that those guidelines are out there and emphasize that you go and have a look at those. We know that survival after cardiac arrest caused by COVID-19 is very poor. It's likely that chest compressions, but not defibrillation, generate aerosol. But as you've seen from the data, very few data to prove that one way or the other. I think all of us would agree that the safety of healthcare workers is a priority. And the challenge actually is not around how we deal with the known COVID-19 person, but it's the whole problem caused by the number of patients that we have where the COVID-19 status is unknown, and where we're probably having to take these precautions before the COVID-19 status has been determined. And that inevitably is causing some delays in resuscitation attempts, which is a great concern, because it may be that there is considerable harm being done with some of the precautions that we need to be taking. But more data, of course, will be collected as we go through, sadly, the second wave and further waves of this pandemic. Thank you for your attention.